There you go. Okay, musculos. Aren't we doing soft tissue? And again, soft tissue injuries. Okay. You don't need to be experts on the A&P stuff in here. But basically, we're going to talk about the skin anatomy, why we have skin. It does things. Like, this is protective layer, keeps bad stuff out, keeps the good stuff in, regulates or assists in the regulation of your body temperature. It's super duper important. What's the largest organ in all the human body? Anybody want to take a guess? Okay, 3 layers. Epidermis, right here. Got little hairs, fatty layers, lots of dead skin. Then your dermis has all the good stuff, all the sweat glands, nerve endings, roots, bulbs, pilia, your veins, arteries. Down here they call it deep fascia. You don't need to memorize all this. You're not going to have to recreate it. It's fatty. And then the third layer, the dermis, muscle. Okay? Then you have subcutaneous tissue. I'm sorry. Sub-Q is where the fatty starts. You don't need to recreate all this, all right? You'll need to have a general idea of epidermis, dermis, sub-Q. Complex. Sensation. We talk about keeps water in, right? Body's, what, 70-some% water? Yeah. It protects against bad stuff getting in, so when you get a cut, that's why we freak out. Wash, scrub, Neosporin, Band-Aid. Head temperature control. Soft tissue injuries. Talk about closed and open injuries. Closed injuries. So think bruising. Okay, big swollen hematomas on there. Associated with blunt force trauma. Your skin remains intact, means it's not cut open, nothing's oozing out, not blood pouring off you. Damage occurs below the surface. There's contusions and hematomas. Who knows the difference?
Contusions are an actual bruise where the capillaries have been, I guess, broken or whatever, and hematoma is bleeding into a cavity.
Anybody disagree with that? That sounded pretty technical. Nice. I wasn't going to get near that elaborate. Nice little picture here. This guy was probably doing some kind of ninja sword fighting with a stick and got beat on. Anybody ever seen that? Medieval recreation stuff? They really hit each other, and I've seen bruising like that. Some people say they're crazy. I think they're idiots. Somebody hits me with a big stick, I'll shoot you. Okay, contusion. Produce when blunt force damages the dermal structures. Blood and fluid leak into a damaged area causing swelling and pain. Presence of blood causes skin discoloration, ecchymosis, bruising. Everybody's had bruising. You'll see this as you go on. You might, when you're looking at this, that looks pretty new and fresh. As the blood and gravity works and your body carries it away, it gets browner, more yellow tint, shows age. You'll pick up on that kind of stuff as you'll go. You might walk up someday on a child that's got an injury and see something that looks at that, and on the other side you see something that looks old. You need to start thinking, okay, what's going on here? You'll get to that when you cover pediatrics more. There you go. Awesome. Pretty common. We have these all the time, victim of falls. Elderly people, they smack their heads off the ground. We see these all the time. A lot of the time you'll see them with a little laceration in the hematoma and actually be bleeding. Okay. Some people call them a blood lump. I don't know anybody that says that. So larger blood vessels damaged, they cause masses of blood to collect in an injured area. Fist-sized hematoma is 10% volume loss. Okay, that's really not that big. You can get on some where people get hit in the side of the head, the forehead, or their eyes, and if you get there quick enough, you can actually sit there and watch them You get older people that fall down, good question for your assessment is, do you take blood thinners? Aspirin, a drug called Coumadin, which is a pretty common blood thinner, given to people who have heart attacks or that have history of strokes. You see something like that, or somebody bruising or bleeding real easy, you always ask the elderly people, you own any kind of a blood thinner. All right? You need to let the docs know that when you turn them in. Closed tissue injury considerations. It says how much blood is tied up in that injury rather than circulating the vessels. That's probably not going to be your first thought. I don't ever think about that, but it's a consideration if it's massive, huge. Most of them you're going to find are going to be an inch or two big, usually on the head, and they grow so big because your skull's right here. Okay, there's not that, all that dermis, epidermis, sub-Q. There's not a lot of sub-Q fatty tissue in your head. I mean, your skull's right here. You can feel it pretty easily and find the formations of the different pieces of your skull. It bleeds easier and they show up a lot faster on your head. Hematomas, all the time. Okay? But they want you to consider that. Think blood loss. What would the force that caused the soft tissue trauma have done to underlying organs? Okay. You all have done kinematics and blunt force trauma versus penetrating? Okay.
Yeah.
So your management of closed injuries. Oh, rest. Ice, ice, ice. Some people used to do heat compresses. We don't use heat compresses hardly ever anymore. Okay. That's well after the injury. It's ice, ice, ice. Heat compresses the next day or 6 hours after. It's not in our setting, pre-hospital setting. But compression, elevation, splinting, if it's applicable. When in doubt, assume the underlying fracture is present. You assess PMS, function. If they're guarding and it hurts, don't go too far into it. Splint it and take care of it. They'll use the magic x-ray machine looking for the fractures, okay? So we, going on these contusions and hematomas, I always refer to them as falls because that's what I see. But where else, probably the most prominent place you're going to see that kind of injury? Oh, okay, fight. Something else that's even more common.
Car accidents?
Car accidents. All the time. It really doesn't take that much to get dinged on the leg or an arm type injury. You'll see bruising all the time. Okay? So if it's mechanism and injury, fast speeds, cars, side impact stuff. We talk about bruising. You see bruising and a T-bone impact at 60 miles an hour, that's the least of your worries. You know something bad is happening inside, and that's what you should be worried about, okay? It should open a doorway to look at, consider the mechanism and what you see with that, and start thinking about what's happening inside, okay? So your open injuries, skin broken, protective function is lost, so water is lost, blood's lost, bacteria can get in. With external bleeding, infection can become a problem. Here's your 5 types of open injuries. Abrasions, that's little road rash, scrape. Laceration is just an open cut. Your punctures, an avulsion. Anybody seen an avulsion? Yeah, it's older people, blood thinners. It's actually, you can take the whole layer of skin and it'll peel off. It's still hooked up. It will be oozing, a little bit of fluid, slick, little plasma coming up. It won't be pouring blood off of it. Will not be pouring blood. It's very top layer. I've seen them cover almost their whole forearm length. I've seen a guy that came in, had the inside of his bicep ripped down to the middle of his forearm. They're not life-threatening, but your biggest, can't go back, infection, okay? So treating that kind of an injury, an avulsion.
So if they have like their skin pulled back or here in the face, it's still called an avulsion?
Yeah, it's skin, okay? Let's remember that it's skin. It's not like the whole muscle arm length ripped off down at the bone. That's not considered an avulsion. It's skin. To treat that, you'd wash it off, rinse it. If there was road rash, something like that, gravel, dirt, sand, wash it off. You pull the skin back in place. 4x4, wrap it with gauze. It will not be bleeding heavily, okay? Then your last class is an amputation. Everybody understand that? Cut off. There's an abrasion. It's a face skid from, you find this bicycles, skateboards, motorcycle wrecks, getting pushed down. I'm drunk and disorderly into a face plant in the road. Okay. It says loss of portions of the epidermis, upper dermis may be rubbing or scraping force. It's capillary oozing, leaking of fluid, road rash. There's a lack, needs stitches. It says cut by a sharp object or blunt trauma. That's probably going to be more common. Again, victim of falls constantly. I picked a lady up the other day, it slipped. She fell down and hit her face on a round doorknob right here. She had a hematoma, it was black, her clothes in her eye was swelling shut. I was watching it grow, and you could pick up right in the crease from her orbit, you could pick it up and there was a huge laceration there. I mean huge. Right? And it was probably not that deep, but it sure was long. But it came from a round doorknob. Okay, blunt force, just hit it just right. They're typically lacerations, typically longer than they are deep, associated with severe blood loss, damage to underlying tissues. We talk about types or linear and stellate. I don't know the definition of a stellate laceration. If you're dying to know, you're going to have to read your book. You're not going to be tested on it. Don't write it in your reports. Write a laceration. When you describe a laceration, you need to do, especially like on reports, so when you did your anatomy, you know, where was it? Was it on the distal forearm or 4 inches left of midline on the anterior chest, or describe them like that, okay? Punctures, nice nail. Stabbing, they're deeper than they are long, typically difficult to assess. Object producing puncture may remain in place in the wound. If you find it in place, do we take them out? No.
Unless.
What if it's a piece of rebar going through their leg and rebar's on a piece of concrete on the ground? Then what are you going to do?
Cut the rebar off the concrete one?
Yep, cut the rebar off. Take it with them. Okay. Warn them that this might hurt a little bit. Try not to use a sawzall. That's awesome. Okay. There you go. Avulsion. Awesome.
That don't look so awesome.
It's pretty awesome. Piece of skin torn loose as a flap or completely torn away from the body. Accidents with machinery, motor vehicle accidents. You'll wash it off if it's appropriate. Replace flap normal position. Treat completely avulsed tissue like an amputated part. Okay, how do you do that? Going to treat amputated part yet? Have y'all covered that? Oh, dang. Rinse, clean, moist, compress or rag or whatever in a bag of some sort, and then wrapped and put in ice. You don't directly put it in ice and freeze stuff. All right. Sweet. They can fix that. Amputation, textbook, disruption of continuity of extremity or other body part. It's cut off. Okay. Parts should be wrapped. Don't sit on scene messing with it. And these, all of these here, that's not. Hold on. Where's the head? That's called a distracting injury. Some people walk up. You get on scene, this is probably bleeding like nobody's business. Eyes opened up, bleeding like nobody's business. You're going to go, holy, you're going to run to it. Okay? Lightning bug, fireflies to light at night. That's a distracting injury. How did that happen? car wreck because they piled their face into the windshield, that's the least of their problems. This is a distracting injury. This is not going to kill anybody. That might kill them if they get tetanus and die. That might, if it's deeper and they get an infection or it just ripped their arm off. But you get a major car wreck. I've worked a major car wreck where we associate avulsion with skin torn loose as a flap. Okay, but I've seen one where it went up from it's probably middle bicep and ripped down, but it was full thickness. You could actually sit in there and you'd see the tendons. And when I got there, he was doing this, and when he let go, it looked like a sprinkler spraying all over the roadway. Pretty awesome. That kills somebody. But in general, somebody gets up, old person, blood thinners, skin's not what it used to be. They fall down, they got an avulsion that covers from here to here. It's just a piece of skin oozing blood. That's not going to kill them. Think fractured hip, head injuries, okay? These are always neat and cool because they look like that. Just always remember all the underlying stuff. Don't focus on this stuff. Okay, partially wrapped sterile gauze, place a plastic bag, transport top of a cold pack. Don't pack directly on ice. Don't let it freeze. Okay. You'll be shocked at what you find cut off. Okay. Huh? Who did? He tell you about? We got a guy here. Cut his junk off twice. No, he's cut it off twice. The second.
He's done it himself?
Yeah. He's sick. That man is sick.
What do you do? Like, I'm tired of being a man?
He's got some serious. He injures himself. I don't think that he's around here anymore. That's sick. That's one patient I don't want to treat. Okay. So open wound management. You see a pattern here? ABCs, control bleeding if it's spurting. Like I said, if it's just a little oozing, that's not the priority. Move through your ABCs, cover anything, look for big stuff. Don't let this stuff distract you because it always looks heinous and cool and you want to, that's awesome, I'm going to do something to it. Okay, you can do something to it later. Okay, have you all covered fractures? We haven't covered fractures yet? We're going to do fractures. Next week we'll cover fractures and splinting. Oh, we're going to cover fractures tonight. I'm so stupid. Anyway, so I'll blabble about that later, but we're going to learn all the ways to splint and bandage and do stuff. And we're going to go to car wrecks. I pull people out with busted legs. I pulled a guy out with both long bones busted, pelvis crushed, and his arm broke. How much of it did I splint? Not a piece of it. I ripped him out of the car, threw him on a backboard, strapped him down, put him in a helicopter, and they left. Because he's bleeding out. It don't matter if his arm's broke, if he's dead in 10 minutes, right? We don't play around with this stuff. With that, we don't make light of it either. Hey, tell him I said hello. Okay. Here's a big one. Prevent further contamination. That's you and them. Okay, you start messing around with these kind of traumas. Exposures. You're going to get an exposure sooner or later if you do this. There's not many people that I know that haven't touched somebody and got a body fluid on them. The definition of exposure could be a textbook or where you work or a policy that the city temple has. If I get blood splashed on me, I'm supposed to get blood testing. Okay? I've been puked on. I've been puked on in my face. I've been bled on, stuff sprayed on me, peed on, got crap all over my pants from people. You're going to get it, okay? So while this is about taking care of them, wash, wash, wash every single call. Wash, wash, wash. There you go on your clinical rotations and you get into something, your clothes are FUBAR'd. Don't take those clothes home and wash them in your kids' clothes. Okay? I wash my clothes at work. Don't take that stuff home. Think about those. Not really part of this lecture, but I'll throw it in there.
Is there a good way to get blood out of a white shirt?
Throw in the trash.
Peroxide?
Oh yeah, peroxide might work too. I was thinking fire, garbage disposal. Okay. So, prevent further injury. Don't necessarily worry about trying to clean wounds out, because at the end of the day, ortho or any, if it's bad enough where they have to have plastics come down, they're going to take it all apart and look at it, clean, clean, clean. A lot of that avulsed skin stuff is going to die and rot off. It'll come off their body anyway. If it's appropriate, it's caked with mud, okay, knock it off a little bit if you have time is appropriate to do so. But if it's a serious patient, do what you need to do to take care of them. Do the most good for the patient. Immobilize, manage hypoperfusion if present. What is that?
Shock.
Bleeding, but bleeding has progressed to too much bleeding and you're not getting oxygen to your melon or important organs, right? Special considerations: impaled, eviscerations, open chest wounds, neck wounds, gunshot. What's an evisceration?
Ooh.
The belly being,
What is it?
so the belly being smashed open.
Guts laying out on the ground.
Yummy.
Awesome.
Did you just say yummy? What a creeper.
You've never done that when you say something gross and you're like, oh, yummy?
No.
You're not really saying it's
I've never done
yummy.
that.
Well, she's about to see pictures of it, so we'll see if she's
Yeah.
sitting on the
So impalement, the butcher knife. All right? A woman did that. You know how I know?
Because they're stabbed down.
That's right. That's a vicious, mean attack by an evil woman. All right? Okay, we already talked about this. Don't remove. Stabilize in place, exception. Next week we'll talk about stabilizing in place, wrapping crap around it. We'll cover it then.
What if he pulls it out?
That's an exception.
Okay.
Okay? Now the exceptions in here, we would remove something like if it's in a cheek. Okay? Cheek into their mouth, obstructing specifically their airway. Okay? We need to protect that. That's one case where we would take it out. Remove dress inside and outside the mouth, and we'll cover that. There's a good picture pencil. He must have been cheating off of his neighbor. Yes. That guy, he didn't make it. Okay, evisceration. Internal organs are exposed to the wound. Cover them with large moistened dressing. We have dressings in the bags. Well, they're probably in the rooms, not in your bags, but they're huge. Abdominal pads, abdominal dressings. They're sterile. You take normal saline, sterile, normal saline, you splash it on there. Keep it moist. Okay. Oh, Mother of God. It says then with aluminum foil. I don't have Reynolds wrap on the fire truck. If you got some, so be it. Whatever you've got. Okay. At the end of the day, we don't. It says this is big. 2 big keys. Don't put anything back in. Just lay it on top the best you can. Put the pad on it. They're going to tear it all out. You'll cause infection if you start stuffing stuff back in. They're going to tear it all out, clean it, lots of lavage, suction. They're going to go through the whole 9 yards and make sure it's taken care of. And then they'll put it back in. And they'll be looking for other damages. Don't use individual 4x4s. Somebody tell me why. Yeah. You know how many lawsuits there are from stuff missing? Pair of clips or something they had pinched off on a vein and then they stuff the guts back in there. Happens all the time. You go, they do Surge Tech next door. They have special sterile bandages and packing that they use to pack around for when they're doing surgeries that bleed a lot. And they're in bundles and they're counted. And when they take them back out, they count them. We don't do that. Abdominal, moisten it up, send them on their way. Our job easy. Actually, it's not. Open chest wound may prevent adequate ventilation. Probably will the longer it's open. Okay. Cover with an occlusive dressing. Somebody tell me what that is.
Can't hold that area.
What's on it? You say?
Just keeps it, it's like a petroleum jelly, not a whole lot
Yeah.
different.
It's a 4x4 that's been soaked in a petroleum-based jelly of some sort. We've got them. You'll see them next week when we play with them. If you don't have something like that, some kind of piece of plastic, who smokes? Nobody in here smokes. Are you kidding me? I'm calling baloney. Anyway, how about that bag right there? That plastic bag will work. That's probably not the most sterile thing in the room, but if you can offset the benefit versus what's going to happen if you don't cover it up, they suck in air, collapses the lung, stop breathing, go into shock, die, or get a little infection. I don't know. I'll take the infection. You'll see it's taped on 3 sides. So that way when the patient breathes, lung expands, fills the space. When they exhale, your lungs relax and go back to their normal shape. When they do that, it creates a vacuum. Air goes in. I've got the occlusive dressing, which inhibits the air's ability. Plastic, a cigarette wrapper, any kind of plastic wrapper. And they take it on 3 sides. So if you notice, as an EMT, the most you can do for them is protect it. And if you recognize that this person's having trouble breathing, you'll see less chest rise here and more here. Or the JVD that Leroy's talked about, you might actually see JVD or a tracheal shift. If this person sucks in enough air, the lung collapses, right? Y'all did airway? Pushes to that side. That lung can expand all the way. The trachea is going to shift to the good side. That's where you'll see tracheal shift. That pressure will build on the pericardial sac, squish the heart out of the way, squishes the great vessels. Blood can't get back like it's supposed to. Blood pressure drops. Work of heart goes up. Heart doesn't get perfused. You're not getting half your tidal volume for oxygen. What's normal adult person bring in? 500 to 700. Take a lung away. Right? You ever seen somebody with lung cancer? Get a whole lung taken out or several lobes, send them out to run a marathon. Probably not going to happen. They can't do it. Okay? You don't do the third one, or the fourth side, so that if you see some kind of shift or signs and symptoms of shock or respiratory difficulty, you can lift it up. It's called burping it. So when they inhale, if it's not a tension pneumo where it won't let the air back out, some will let air go in and out. Some will just keep the air in. When they inhale, their lungs expand and you hold the little flap up. As their lung expands and fills the cavity, the air will rush out, and then you let it go and it'll cap it off. Okay? Air's still going to get in there. It's not perfect, but it's called burping your dressing. Never done it, never seen it done. But you could save somebody's life with that right there. Okay. Occlusive dressing is what we have. They're on most ambulances. I don't know anybody that doesn't have them. Okay. Use them on any kind of wound in the chest. There you go. Minor patient signs, symptoms of air being trapped under the pressure in the chest, called a tension pneumo, causes signs and symptoms of shock. Tension pneumo develops, lift the dressing to relieve the pressure. You'll be able to tell by, if you did good, you'll listen. Good breath sounds on the good side, diminished or no breath sounds, and they're going into shock, they're dying, you can tell. You burp it and then listen again, they start acting normal or more coherent. Their heart rate might drop some. It's not trying to compensate as much. And now you'll hear better breath sounds, okay? You're always reevaluating breath sounds on these people. Work of breathing. Neck wounds. Sweet. Risk of severe bleeding from all the large vessels. Neck's not very big, okay? There's a lot of stuff in there. Doesn't take much. We start IVs in people's necks that are severe ones. I can't get it anywhere else. Right here. The risk is the same thing as before. I can get air. There's so much fluid pulling back down, it can vacuum and pull air in. That's the theory. I've never seen it. It usually squirts blood out like crazy, but you need to protect You won't be doing the IVs or any kind of puncture wound, major laceration to the neck. We use occlusive dressings here again. You have a risk of air entering the vein and moving through the heart and the lungs, causes an embolism, right? Cover with an occlusive dressing again. Do not occlude the airway or blood flow to the brain. We don't tie tourniquets on people's knots. We don't do pressure dressings with Curl-X around it and cinch it off. Okay? There's a lot of stuff that's got to happen. We'll show you how to bandage up a neck injury next week. And always suspect presence of a spinal injury if any penetrating trauma in the neck. Gunshot. Special type of a puncture wound. Transmitted injury can cause injury remote from the bullet track. Unless you're a ballistics expert and you know what was fired, you can't predict what's happening. Okay? Bullets change direction. It says here they tumble. Some come to pieces and hit everything. If it's a shotgun blast, and they're using bird shot, lots of little pellets of stuff could be everywhere. Maybe it's buckshot and it's got 7 pellets on it. But they're, this big. It's just hard to tell what's going to happen. So don't always assume that we never know the track. Here, how many gunshot wounds do you see?
2.
That's right. It's probably in and out, but we say 2. We never call an exit wound. We don't assume it's an exit wound. We say, I have 2 GSWs, gunshot wounds. Okay? They'll figure out if it's one entry and exit. It's impossible to assess severity in the field. Patient has to go to the OR. This is super important. Anything from right about here to right here, pretty important. Okay? Any great vessel, even these people that code CPRs, you have a chance of saving this person in a CPR, even though they're bleeding out, versus blunt force trauma, car wreck. And those people are dead and you pull them out to do CPR. The statistics on them, I think, are less than 1% across North America. You are not going to save them. Gunshot wound, penetrating trauma, you can save those people. Okay? So if you get this, think it's always ABCs, okay? If you're going to go gunshot, people are screaming to it, I'm going to get there because I'm going to do stuff. I'm going to put occlusive dressings, I'm going to do this and that. ABCs, okay? If this is thorax, what am I going to do? Chest wall injury, what am I going to do to it? Occlusive dressing, manage ABCs, vital signs, look for any other. It's cut, expose, expose, expose. And I mean expose. Cut off everything. They got leather chaps on. Don't cut my leather chaps. Sorry. That's what they got insurance for. All right? Takes care of that stuff. Probably doesn't pay for leather chaps, but that's what we tell them. They'll fight you for their leathers. I promise you. So when you get into these, treat them the same way as any other blunt force trauma. It's always ABCs. If it's bleeding like crazy, fix that. And then go do your head to toe. Look for other. There might be, when you roll into your back to do C-spine stuff, you going to do C-spine on somebody who's been shot? Yeah, you probably are. I can take you up and show you a doctor up here that we did C-spine on somebody that was shot in the head. He said, what do you do that for? All you did was waste time on scene. Because we thought we were going to get smacked if we didn't do it. That's why we did it. Go ahead and do it. You'll decide down the road if it's important or not, okay? What else? Anything else on this? Occlusive dressing. Yeah, I got something else. Gunshot. You probably covered this in your abdomen stuff. Navel to here. Gunshot is chest trauma until proven otherwise. Okay? Right? Because if I'm inhaling My diaphragm moves down. I could have been at the peak of my inspiration and had a full lung expansion and got shot right here, and it perforated the diaphragm in a lung. And then I exhaled and there's nothing in the abdomen, but we don't assume I have a gunshot wound to the abdomen. Okay? And likewise, anything from the nipple line down to, I think they say somewhere, periumbilical area is abdominal until proven otherwise. We don't assume that. We let the hospital hash it out. You need to be aware of it for gunshot wounds, knife, that anything in here could be damaged depending on how they're breathing. We really don't know. Okay? So assume both types of trauma are present. Be looking for the trauma types as far as quadrants, what organs are where, and always managing ABCs. Okay? Sweet. Any questions? Really? All right.